Welcome to Kentucky Tonight. Good evening, I'm Bill Goodman. Tonight we'll discuss health care. Our guests are Melodie Shrader, Executive Director of the Kentucky Association of Health Plans.
The American people right now are interested in health care reform, but they want to make sure we do it right. We don't want to turn the system upside down only to find out we've done it wrong and taken a step down the wrong path. I think there seems to be a lot of agreement on things that we do want. We do want a guaranteed issue. We do want to be able to renew our plans. We do want portability. And we do want those who absolutely cannot afford health insurance to have health insurance. Those are the things I think we're agreeing on. I think what the American public is concerned about is that we do it right and we don't make a misstep at this very important juncture in our history.
Don't both Democrats and Republicans agree that they do not want insurance companies or plans denying coverage to any individual?
I think so, yes. We're very much in support of guaranteed issue across the board, but it has to be done at the national level. I mean, we've talked before about the fact that Kentucky tried to do this as an island, and it cannot be done at an individual state.
When you say on a national level, though, but you would not assume that that is a so-called public plan or
no,
universal coverage?
No, I would not
What's
assume
the difference
that.
then?
I would assume that you can walk in and get insurance anywhere in the country and that we are guaranteed that ability. So, in other words, our high-risk pool here is going to go away because we're not going to need that because you're going to be guaranteed to get insurance in the market, and everyone is going to have a level playing field from that perspective. So, but that does not mean that you go to a government plan. That means that you would actually be able to walk into any company and they couldn't deny you. And I think we all agree, Democrats and Republicans, that that's an important issue. I'd like to add one more comment, though, because I think you're dead on with the discussion about the patient and the doctor relationship. But there was one component I think you left out, and it's a big component as far as the discussion at the national level, and that's the individual responsibility.
Personal responsibility.
Absolutely. Oh, yeah. We in this country have, in this debate, confused health status and health outcomes. We say, okay, well, you know, we spend more than anybody else in the world on health care, and yet we're 41 behind Chile and Panama as far as our health status. Well, there's probably a reason why Panama can spend, I don't know, $10 per capita, and they still live as long or longer than we do. Right. And I think that has to do with our health status, which goes back to obesity and just personal choices that we as Americans make that impact a lot of our health care.
Well, take that point just for a moment, and we'll stay a component for personal responsibility to take a more personal responsibility for your own health status.
I think that is the most difficult part of this whole debate, is how we change the psyche of the American public. But until we really address that issue, we are not going to address this skyrocketing cost, because to your point, Americans are still going to want the best technology. We're not going to want to stop investing in that technology. We're going to want to know that no matter how unhealthy, no matter how many bad choices I've made over the years, that when I walk in with a heart attack, that my health outcome is going to be better than it would be if I walked in with that same condition in Chile or Panama or the United Kingdom or Canada.
Public plan.
Well, the public option is going to be a plan that's going to look like Medicaid and Medicare. I mean, that's going to be run in that fashion. The option to that would be to say, just like we do today, you must have car insurance. The difference would be...
It would be mandated.
It would be mandated.
And purchased.
The difference would be that if you could not afford it, unlike with a car, you need to stay home and not drive. We're going to say that there's going to be a ways and a means of making sure that that is financed for you, whether it's through tax credits or through subsidies or through vouchers. Mm-hmm. That's the alternative. You would still buy it in the free market. You would still have the ability to choose which plan you wanted. For example, many people today, I know I am self-employed, my plan is not as rich as it was when I worked for an employer, but my health status hasn't changed, and I would say my health care is just as good. Now, I've made some purchasing decisions that are very different. I have a $5,000 deductible. I walked into the doctor's office a couple of years ago with pneumonia. They knew my chest was rattling. They said, I was walking pneumonia, thank goodness. They didn't need to put me in the hospital. Said, let's run an x-ray. And I said, well, what does that x-ray cost was my number one question. And the doctor said, I've never had anyone ask me, and I don't know. So I said, okay, let me ask my next question. I said, you know, what is going to be my treatment plan? What's going to be different about my treatment plan if you do the x-ray versus not? And the truth was, there was no difference. The deal was, if I went home and they sent me home with this bag of medicine and I didn't get better in 5 days, then I was probably going in the hospital regardless of whether I had the x-ray or not. So we took the option of not doing the x-ray, sending me home with the meds, and sure enough, in 5 days, I was better. So, but I made a purchasing decision there, and that's very important, going back to this personal responsibility, and I'll add that on too. What I believe is important today if we want to control cost, and that's actually asking questions. Because I will tell you in healthcare, and I'm certain with these two doctors sitting next to me, that price and quality are not necessarily tied together in healthcare. I mean, I think everyone would agree that that's not true. The cost of a heart procedure in a hospital that only does one per year is probably going to be very, very expensive. And yet their outcome is probably not going to be as good as a hospital that does 1,000 a year.
Do you agree with that, doctors?
Yes, yeah, that's true. I mean, a lot of times, I mean, again, it's, you know, the thing I've always been a fan of, what I have in my own practice, is health savings accounts, in which we're permitted to make those decisions ourselves. And, you know, it makes people financially responsible for their care.
Who does that? Taxpayers.
Well, the taxpayers pay for it in the form of dish payments to those hospitals. That's yet another complication that we haven't even begun to touch on in this debate. Is there's a discussion at the federal level that we would limit or do away with those dish payments, because theoretically we'll have covered the uninsured with these plans. Unfortunately, that won't be the case completely, because we will still have folks that don't have insurance. Of the 46 or 48 million Americans that are uninsured, I think it's 11 million of those are undocumented aliens. So those folks are still going to be undocumented, and they're still not going to be covered under any plan that's being discussed at the federal level. But if they get sick tomorrow, they're going to show up at the hospital, and we are going to treat them, because that's the way we operate in this country.
Are they not classified? They're classified now as uninsured.
Yes, they are, but they get treatment. But they get They are classified as uninsured, but they get treatment. They'll be classified as uninsured under any plan that's being considered that I'm aware of. But they will still, I argue, would still get treatment and should. So we've got to pay. We've got to figure out in this whole payment system, you can't just do away with the money that we've set aside for indigent care, because there still will be folks that don't have insurance.
In either the, excuse me, Dr. White, go ahead.
I was just going to make the point that hospitals also, the non-profit ones, are required to do so much indigent care, but they get a tax advantage because of that, which again is essentially transferred from the taxpayer.
Absolutely.
So that gets us back to the whole question of the access, and how people that don't have insurance or do not have access to financial resources.
To something Bill said, because I think there is, where we started, Bill, and that we agree on quite a bit, and we can debate a lot of personal responsibility that absolutely needs to be put into the system. We need some accountability. We need to be asking questions. But we do need to create a system that allows access. And for those 12 or 13 million people who want access today, they want health insurance, and they cannot afford it, that is where I think we need to be focusing our attention. And there's going to be a lot of folks who, they're not going to walk into the system no matter how you structure it. But there's 13 or 14 million people that want to be in the system. They cannot afford it. They've got chronic illnesses, some of them. They can't work, and they can't, they don't have employer-offered program, but they don't qualify for Medicaid, because there is a misconception in this country that being poor qualifies you for Medicaid. And maybe in other states it does. Being poor in Kentucky does not qualify you for Medicaid. So I think there is a place where Bill, you and I 100% agree, and that we need to be framing this discussion about how do we get those folks into the system, but at the same time not leaving out those very important components of personal responsibility.